Hello and welcome from the Clinical Nurse Specialist Association of British Columbia, or CNSABC for short.
So thank you again for that. I'm here to talk about the CNS role in system changes across the care continuum, which I think all of us being CNSs, all of us are actually already doing it. Okay, let's see if that works. So again, just acknowledging that I'm calling in from the traditional, ancestral, and unceded territories of the Coast Salish peoples here in White Rock. And I just want to show you my timeline as to how I get entrenched with this work. I just started in 2020 in my role, and I got redeployed from ICU as we upskilled, the many levels of healthcare teams, including our physicians who were in clinics then to help in ICU. And so once that kind of settled in a little bit, I got pushed into within a few weeks of saying yes to the CNS for the older adult. I got redeployed to long-term care. And as soon as that finished, and so once we got back, and then we got now kind of pushed into the typical CNS role into, okay, we got to finish all the policies that's related to delirium. And I just want to acknowledge that even before we started doing that, there's many other key stakeholders that were already doing the work. So it started somehow in 2010, and with primary care colleagues, Dr. Grace Park, she was doing this work way back in 2006, 2007. And perhaps Patty could also have much more historical context than me. So thank you for all that work that led to when I did join the network in 2020. So in 2015 was when Fraser Health owned delirium advocacy for the older adults. Then again, there's so many other folks like Dr. Jean Warnebolt, a hospitalist from Eagle Ridge, that was doing all the work, recognizing that we do need a standardized care plan, a PPO, a pre-printed order, which was also regionalized around about that time. Delirium was then made as a patient safety priority. And again, with that system lens, I kind of felt we should not be only dealing with delirium, and obviously not just for older adults, but again, as part of the, because of the pandemic, then it did illustrate that our older folks are more vulnerable. So delirium has always been a priority, even in the ICU and the surgical world, obviously across all ages. And a dashboard was in the works at that time as well with systems optimization. So after redeployments, then when I came to the network in 2020, we kind of fast tracked everything from policy to CDST, which Marie Blair, the former CNS, already updated at that point, and many other key players. And so essentially, we kind of updated, revised, and revamped, made it easier, more accessible for our frontline clinicians. The delirium toolkit was also revised, and by 2021, another series of delirium summits did happen to bring people together, which is what CNSs do. We're kind of the hub, the bridge of everyone. With that, we revised, or we developed a delirium change package after doing so many service mapping, and to figure out really what are the opportunities and the gaps in the care that we're doing. And this is just delirium. As we know, there's many other patient safety priorities and many portfolios that we have. And some sort of a change package is always needed to really just bring access closer and make it easier for everyone, which is a CNS role. By 2022, we engaged a lot of people, including the surgical quality improvement program. Spread QI also got buy-in with now key surgeons and anesthetists in PSARCH. help with hip fracture patients in decreasing and localizing their anesthesia, which also decreases delirium. Pharmacists also did come into the picture, and they decreased their antithrombolytic days. So instead of 2 weeks, it was decreased to 6 to 7 days. And obviously, there's a huge increase as well and huge uptake with delirium screening. And that obviously decreased delirium cases. Well, initially, it did increase delirium cases because now we're recognizing it more, but hopefully at some point it would normalize and trigger the tools that we have all revamped and revised. We've socialized this with Health Quality BC. At that time, it was called BC Patient Safety and Quality Council. And we've socialized this as well, almost simultaneously with PQI within a year. Partnered with geriatricians in a key tertiary site in Surrey. And Fraser, I'm regional, so we cover 12 sites. So other CNSs, welcome Fiona, who is now the CNS for critical care. She started a delirium project as well in Abbotsford. Of course, there's many other key players. Sharon Hicken was already doing her delirium project with RCH at that time. And then we engaged the 14 long-term care sites as well to reduce antipsychotics to pre-pandemic levels. Then we've started, this is the kind of laying really the groundwork where CNSs are really good at is knowledge translation. So I'm not the only one teaching. I think probably just taught once or twice, but it's really engaging specialists. Marsha was there as well, and a lot of her patient partners also did lean in and explain, what it was like to be on the receiving end and what is a good day like, what is a good care like. And so that humanized, normalized a lot of the things that we're doing at the bedside and made it kind of hit home better. And so it's kind of a true bench to classroom to bedside. 30-minute session and 15 minutes Q&A weekly for a year in 2022. And that was a lot of work and a lot of engagement. And then last year we did every fortnight, so every 2 weeks. Physicians were engaged, front lines were engaged from acute all the way to long-term care. We have executive leadership also attending those sessions. So from the previous Delirium Summit, by the second Delirium Summit, you would now have seen a difference in engagement. Initially, it was just physicians presenting, but by the second Delirium Summit that same year, so I think we did December 2022, then November 2023, we could now see, we even have UBC, a PhD candidate from UBC also presenting at that time. And we have way more engagement from CNEs, CNSs were presenting, surgical, medicine, as well as long-term care presented, and pharmacists, and of course, physicians also presented. So by that time, momentum was really, really picking up. And we've partnered, of course, with our key players as clinical quality and patient safety, professional practice. So we've embedded delirium education even in acute care orientation. So as the momentum was picking up, then our key stakeholders were also picking up and making everyone understand that, this is village work. Like there is no way I could do it all or the network could do it all. So with all those partnerships, the aim now is to have delirium prevention and frailty prevention across the care continuum. There is, it just didn't make sense anymore that it's just acute kind of dealing with delirium when we all know the biggest or the bigger piece of the pie really, and the biggest gains would be in primary care prior to patients getting worse. So then we partnered with primary care. Of course, Dr. Grace Park was one of the pioneers for that. And then there's social prescribing. We have other CNSs, obviously buying in as well as executive leadership. And then we got in the fellowship with the IHI. And with that work, with that delirium work from one site, within 3 months, it was rolled out in all 12 medical areas in Surrey, and it is now rolled out across Fraser and sustained locally as the regional delirium strategy. This is just a simple example of what CNSs do. So I just want to acknowledge too that the delirium data dashboard went live last year, and this is not my work. It's systems optimization work, and obviously we work with them along with Frontlines, particularly Surrey, who trialed this and making sure that the specificity of the dashboard is accurate so that it could predict cases or patients as they get admitted to the medical wards or even in emerge, and basing on demographics and literature and CAI data, it would spell out the patients that could potentially develop delirium, and then obviously it would highlight to the bedside, particularly the PCCs, and help with assignments as they do their assignments and huddles to highlight these patients that could potentially develop delirium, do the CAM screening once a shift, and then that would trigger the rest of the tools, and hopefully they could intentionally round on delirium, and then there's more documentation of delirium in both nurses and physicians' notes, and then as the patients now get transitioned to other sites, hopefully the physicians are now documenting it, including resolving delirium or whatever treatment did happen, just so the next group of clinicians do have an idea that the delirium is still resolving, or whether the delirium has resolved, and therefore they're increasing potential to redevelop it again is always looming. So just that knowledge, and again, this is how we get it coded, which is very important. So again, a key player that we did partner with would be the HIM people. And so then that triggered as well the creation of new positions, which are important to complete the delirium screening and treatment of our patients. So we now have electronic medical systems coming, and we have HIM specialists. So we have Hanifa in Eagle Ridge, and we're hoping to see new HIM people that would help us code better and obviously address better our patient safety priorities. I just want to show a few of the PDSA cycles that we were doing, which again, we PDSA per se, so it's a plan, do, study, act cycle. I also, in full disclosure, at that time that we were trying to deliver targets, I was endlessly finding a language that would help me understand what does executive leadership want from us, from the network, say for instance. So we have our targets. How do we align our targets with what executive leadership wants? And just so we could help the front lines that are doing the work really translate the work so we all align to what is needed to be achieved. Naturally, we would do literature reviews, environmental scans, we forge partnerships. So this is just an illustration of how we get buy-in and funding for our workforce well-being work. And this is now being rolled out in Fraser as well. So the logistics planning with a shared work group, and of course, very, very important early on is seeking leadership support, because otherwise we can't sustain the work that we're trying to do. And of course, anchoring this to the bigger health quality or Healthcare Excellence Canada, whatever opportunities are there, there could be research as well that we could anchor our work. So depending on capacity as well. And so is another way of sustaining the work. Another PDSA cycle that we did is always conducting training. And so it always starts with meeting with fellow CNSs and CNEs and checking in if there's groundwork for mental health training readiness and buy-in. I've sought professional practice and, of course, the chief nursing officer's support if there's anything that is already there, so we don't have to reinvent the wheel. Obviously, feedback is always continuously sought just to see whether is this doable, and obviously pivoting if we can't. Cycle tree involved a shared work group for content and format and duration, which again, we're doing almost intuitively as a CNS. And then initial sessions were piloted early December, and we've received feedback. And so by end of January, we're actually doing an initial cohort for train the trainers. And hopefully we could tailor fit it to the rest of Fraser. So for now, it's just for acute care staff, but we've opened it just because of funding. But we've also opened it, so depending on the project that we're doing, so and the funding, then we pivot accordingly. And the last ramp that I just want to show is, again, this is about giving people access. How do we, another thing that I think CNSs do really well is how do we devise an effective communication and marketing plan? And so knowing one thing that is important, so we do have a gut feeling, depending on our portfolios, what is needed. We do a literature search and we do an environmental scan and initial data gathering. Obviously, content planning with shared work groups, devising a communication plan. So from my end, I went to professional practice. I went to the chief nursing officer. I also went to employee engagement for better sustainment, because they are the experts on this, and just putting in the clinical lens. So this is the plan. So January, February, continuous training of cohorts, and then monthly training onwards. What did I learn about people, systems, and me? So I'm using appreciative inquiry really as one of the kind of my way of articulating how I feel and what I think about where CNSs sit in the political landscape. The assumptions are, in every society, organization, or group, something works. So I knock on people's doors, and if I say, if I get a yes, then I go ahead. If I get a no, then I go to plan B, which I'm sure all of us do as well. And then once we focus on something, I think it becomes our reality. It's almost like when you really want something, the universe connives to give it to you. So then we see people that are engaged. We call them our early adopters or our low-lying fruit, and then we align with them. A shared reality is then created at that moment. And as you know, there are multiple realities and there are multiple priorities as well. So it's always just going with the flow in a way, and at the same time assessing where things are at. I also ask a lot of questions and group influences in the same way. I get feedback and go by the feedback of people. In that way, it's a shared reality, it's a shared work, and therefore it's collective. I also think that there's a lot of it has got to do with people having more confidence in what we have done in the past, and at the same time having a sense of where we're heading. So then we have more confidence and comfort to journey to the unknown. But at the same time, there's also a certain reality there that we do know that the lessons of the past, unfortunately, been nursing for 30 years in 3 different continents. And I just know that we can't carry on doing the way we have been doing things. So therefore, there is always time for the right work. It is also important to value differences, and that the language we use creates our reality, really. So basing on the responses that I get from people, I tailor fit the next steps. So it's almost like sometimes when we're at the fork and there is no path really. And I think that's the truth for most CNSs, especially that there is a huge, how shall I say it? There's a huge question of, standardization for our competencies as CNSs. What led us to where we are now? What exactly are we doing? Is there a way to standardize the way we are doing our business? What is the best way forward? Are programs the best way forward? Are networks the best way forward? I don't know the answer. I'm just putting it out there. But these are my lessons of the last 3.5 years. And this is the change model that I follow. So I think knowing that we can't do the way things have been done in healthcare. Back in the day, I used to think that as nurses, our job was, say, if your bedside is to look after our patients, whether you're in ICU, in medicine, or in surgery. Physicians were meant to diagnose and create a care plan, and therefore we complete and complement each other along with the other members of the healthcare team. But because of COVID, or the lessons of COVID, we now know that really there's a higher calling out there. Like most of us, including our executive leadership, actually don't really know what the next steps will be. Therefore, a collective answer and co-creating solutions is really needed. It is my vision to see nurses, particularly CNSs, working, say, with a regional medical director and executive leadership in every table is the way to go. I could be very simplistic in thinking that, but I just think executive leadership knows operations. Obviously, we need physician engagement. And of course, we bring in the system lens, the research lens, the policy lens, the standards lens. And we also bring our flock with us. So I'm always being cognizant of nurses have a nurses talk, physicians have a physician talk, and obviously EDs and Ds have a D talk. So I always feel like this orange bit sounds real to me, which is creating a sense of urgency around the single big opportunity, never letting up, and formulating a strategic vision and develop change initiatives that are designed to capitalize on the big opportunity. So say, for instance, to illustrate, if it was delirium that we were working on, and so then it was delirium, it's finding every other opportunity around it. How do we embed it in practice? So one of the things that we found out was that the CAM was not embedded in the medicine flow sheets, but it's embedded in surgical flow sheets. I have no idea how that came to be. So then that was a single big opportunity that we did. We don't know if it's going to work, whether, teams would adopt it, but we had that feeling if that was the ask, and, obviously the ask makes sense. We did a literature search, we did stakeholder feedback. We asked professional practice. We asked clinical quality and patient safety. How do we do this? We then sought QI, quality improvement, to give us boundaries as to how we're going to trial these things. And lo and behold, everybody, the stars aligned. Everybody, it was tedious when we were starting because we were making changes almost every week. And of course, we found a fertile ground that was very, very engaged, and that was Surrey and the quality teams that are already there. So then we embedded it in the flow sheets. We now have to institutionalize the changes and put it in the culture. We build it and we maintain a guiding force through daily huddles, and we have trained the trainers. We celebrated visible, significant short-term wins. Every time there is a change or every time there is a win and a change, we celebrate them both. There are no wins. There are no failures, just constant learning. So again, it's context matters. Then we communicate the vision and the strategy to create buy-in. So we constantly, we've embedded it in our network goals. And of course, with the way we communicate it, whether it's in our shared work groups or in our meetings or in our huddles, it's always putting this at the center. Like, what is our why? Why are we doing what we're doing? And then we accelerate it and move towards the vision and the opportunity, ensuring that the network removes barriers, of course. We were even able to hire significantly geriatric nurse clinicians by providing the data that really what we're doing matters. So it's almost intuitively, we're just at the fork, we 3 steps forward, and then the road shows, and we just do the next best thing forward. Of course, guided by the principles of QI and our key stakeholders that are there. So we did develop a local, every site has a local delirium steering committee, and there's also a regional delirium steering committee. And so that those are the key players that guided the intuitive movement of the project. What was the emergent strategy? Any change is good, so small is good and small is all. So, and then the large is a reflection of the small. So every small win kind of cumulatively makes the win even bigger. And then change is constant. So whenever there's a change, there's, you know, setbacks or whatever, it's always what can we do to make it better, or how do we make this better and not add on work. Context building is also very important. So we try to change the context as not adding work, but it's a standard of work. So it's essentially going back to the basics. So, and again, there's always enough time for the right work. And there is always a conversation in the room that only the people that are really, really very engaged and at that moment can have. And so always seizing that moment to find that conversation. And again, never a failure, always a lesson. So this is our network goals. And just like our the cascade of birds as they go in a specific formation to move and go with the flow of the wind, I think it's the natural cadence of things and the momentum and really just listening into each other that really helped us move this very big work. Small steps, but now it has evolved to become the regional delirium strategy for Fraser. And we have spoken about this in 20 conferences, local and international last year, that culminated at the Institute for Healthcare Improvement and a BMJ Open publication. This is, again, an illustration of the synergy that CNSs can do. I sincerely believe that really CNSs is the inertia that healthcare needed at this point. I just want to show you this, that we are just being granted a runner-up for Health Quality BC, and I want to honor it's not just us. You know, we have our fellow Shannon, who's also a winner as one of the key players, and it's so heartwarming in this cold day to really see older adult clinicians being celebrated up there. I want to just take a moment for all of us and just ask these questions for us, like the space and time for reflection. And some prompts here would be, when did you last feel your work was effortless? And a story about something that really matters to you and something you've accomplished that you are proud of. I could start by saying that I think my biggest gift is really to be a bridge. And that's the challenge I pose for all of us CNSs here, that really, this is why I do what I do. This is another prompt. So when was the last time you were wildly happy? And use all of our senses to describe this moment. Maybe I could start. I moved here from London, England. I was the head of ICU research. I was an ICU sister, as we call it, back in London, England, in hemato-oncology. So my specialty was leukemia and bone marrow transplantation in the ICU at the Royal Marsden, which is the Center for Cancer Research in all of England. And the joy it brings when we can save people's lives is really amazing, because they come, leukemia comes to you and you don't see anything wrong with them from the outside. They're young, robust, and yet obviously their blood is full of cancer. And some are, like vegan athletes, and you don't understand why they have it. And so then to give the most the hardest of treatments in a transplant to top it off, and to see them kind of go through that, go really sick, and hopefully recover. We've seen people that do recover. It gives me an immense sense of pride to have been part of that care planning and making it available to all. So even then we were advocating that this, I know it's very, very kind of stressful to the body, but we made it available even to 70-year-olds at that time, trying not to, improving access to a lot of folks and not discriminating basing on age. So that for me was really, really a good time. But I think these moments humanize us and really tell us our why. How have we tried to make healthcare better? So first we have the era of standards, which we still do. Then the era of evidence and measurement with Deming, and of course the Shewhart charts and everything that QI is prescribing. And then the third era is the era of collaborative improvement, and how can we really sustain and spread this QI dosing that we're doing. Obviously, I'm not saying that QI is the be all and the end all. It's far from it. I just find QI to be a good vehicle, and people don't feel judged for what they're doing because we are improving, and therefore it has a positive spin to it. It's also the language that leadership wants. Therefore, I learned that I have to learn it fast so we could get buy-in from leadership. I also want to share this. Wiring the Winning Organization is one of the good reads that I just did. And this is, there is no way of doing healthcare now, doing QI kind of in many different areas, but because there's just not enough time. The challenges are huge, and I think embedding quality is the next phase of the challenge, really. And what does embedding quality mean? So again, putting the value and credit where credit is due. So our people are our most valuable asset, and that includes CNSs. And I'd like to see CNSs given more value in the healthcare system. Complexity needs stronger default systems, so more standards, more default systems, particularly in patient safety and medication safety. As we all know, we're welcoming HCAs in acute now in Fraser, and as much as we are welcoming them because we need all hands on deck, I can't help but feel a sense of foreboding, really, with all the near misses that we could potentially have. But of course, there's ways to mitigate those. We also have the social admonitions to improve culture rarely work. So we need to see more than lip service and embedding it in just goals. We really need action. We need executive leadership and everyone to demonstrate this. And then to really put safety, quality, equity, and patient experience in one big bucket. They can't work as silos. And of course, real transparency, not only to staff, but also to patients. So involving patients, so what matters to them and also what matters to staff. Just thank you. Thank you to all. And the truth is when the going gets tough, really, all we have is each other. We are our brother's keeper. And then we find a sense of purpose, purposefulness, connectedness, and hopefully it'll bring us joy amid all the chaos that we have now. Thank you very much. I think I'll end there.
Thank you for joining us. If you would like to learn more about our association, please visit our website at www.cnsabc.ca